about pretty significant etiologies of high filling pressure, including cardiomyopathies, of course, pericardial disease, et cetera. So hepatopulmonary hypertension, hepatic hydrothorax, cirrhosis-related cardiomyopathy, and I know I'm forgetting one more, but let's see what else people have in there. Oh, and then I think, Hans, your point about just sort of the metabolic parameters being extremely high risk for bleeding and having significant symptomatic anemia manifesting as dyspnea will be an important consideration as well. So yeah, love it. We're climbing up the pyramid, but we're keeping in mind the kind of complications that can happen with a severe portal hypertension. That's sort of one of the manifest problems in cirrhosis. What else you got for us, Zaven?
Great job. So a little bit more of the story. He was diagnosed with cirrhosis about 2 years ago. The initial presentation was one of abdominal distension, and had a scan sort of showing cirrhotic morphology, and had appropriate workup, and the etiologic presumptive diagnosis was alcohol-associated cirrhosis. Since that time has been kind of in and out of care, but mostly doing okay at home, not really engaging with the healthcare system too much, until about 2-3 weeks ago, had noticed that sort of a baseline level of not being very fit and not breathing very well had started to get worse and accelerated to include severe shortness of breath with any exertion and even at rest, some associated orthopnea, and definitely associated swelling of the legs, as well as a little bit the abdomen, but mostly the legs. There's no cough. There's no discomfort in the chest in terms of pain. There's no fevers. There's no chills. There's weight gain along with this worsening edema in the legs, and otherwise hasn't had other kind of changes in or exposures, hasn't had sort of viral symptoms, hasn't had sick contacts, hasn't had travel or changes in medications or any other kind of circumstantial differences that may be helpful. I'll fill out just kind of the rest of the history and pause there. So other than the cirrhosis and alcohol use disorder, has been healthy. He was able to stop drinking about a year ago, and otherwise lives with his spouse, and used to work until about 1 or 2 years ago, around the time of the diagnosis, and hasn't been working since then. Just kind of hangs out and enjoys kids and grandkids. Doesn't smoke or use other substances, and no longer alcohol, as I mentioned. So for the medications, he's been previously prescribed spironolactone 50 milligrams and furosemide 20 milligrams, but ran out of those prescriptions some months ago and didn't refill them. Otherwise takes no medications. Nothing on family history, no allergies. And that's about it, but I can answer any follow-up questions for sure.
Great. I'll kind of share the direction my thinking's going in and see what other comments and pearls everyone else has. So we're really framing this as sort of subacute worsening dyspnea in someone with cirrhosis, with, some symptoms that are consistent also with general total body volume overload, with the leg swelling and the ascites also. I think the broad differential that we sort of initiated with primary pulmonary causes as well as cardiac and submetabolic is still pretty wide open. I just wanted to make a comment, particularly about the orthopnea, and really thinking about how to avoid anchoring a lot of the time on orthopnea, meaning heart failure. Orthopnea, right, is someone getting more short of breath when they're lying flat, seen in decompensated heart failure for many reasons, including the increased kind of venous return and volumes that get pumped when someone's lying flat. But generally being short of breath when you're lying flat happens when you have a really big belly too. And a really important cause of dyspnea in someone who has cirrhosis that we didn't explicitly address in the beginning is massive onset ascites. It just impairs diaphragmatic excursion and makes their respiratory effort more difficult. And as you can imagine, makes it way harder to actually breathe when you're lying flat. So that difficulty breathing lying flat, I think, keeps some of those, primary cardiac increased filling pressures factor on there, but just diaphragm impaired mobility because of massive ascites is actually a really common cause of this symptom. There's a lot of patients whose dyspnea goes away when they get a large volume paracentesis and feel better. So with the specter of a lot of volume overload in this patient who's been off diuretics, thinking outside of the lungs to the lung kind of bellows breathing apparatus, the important requirement of having a diaphragm that can move up and down is just an important category to think about. And this guy having been off his diuretics, et cetera. Let's see, I'm sure there's other great thoughts in the chat here. Oh, Hans, great. Just thinking about just the other organs his chronic alcohol use in the past could have caused some damage to. A year of sobriety is fantastic for him. And I think so important we encourage him, of course, as his physicians. But yeah, there's a lot of other factors that could have factored into that. And so wondering if for some reason a dilated cardiomyopathy from prior alcohol use that isn't manifest anymore present is a really important thought too. And yeah, Anne-Marie, I love the thoughts too about the way the the kidneys can be affected also. Really important to think kind of with our other organ systems. Again, for the dyspnea, I think with additional history, we're very much still honing in on the cardiopulmonary, as long as we include kind of impaired diaphragm excursion from massive ascites here. Kind of the lack of fevers, the lack of chills, lack of exposures. At this time, I think infection feels, a little bit less likely than other primary pulmonary or cardiac causes, but not a normal host. Anne-Marie made a great point just about general risk factors for not just common infections, but other ones like cryptococcus. So we'll have to sort of keep that widely available as we do still, I think, a pretty broad workup for this guy. What else you got, Zaven?
Temp 97, pulse 100s, regular, blood pressure 110s over 70s, respiratory rate is in mid 20s, 26, let's say, and O2 sat is 92 on room air. She is looking a little dyspneic, uncomfortable, kind of tachypnic, working a little hard to breathe, but otherwise is alert and communicating well. And her, I'll just say off the bat, she has sort of stigmata of chronic liver disease. She's a little bit jaundiced. She has spider angiomata, and her JVP is about 15 centimeters of water. And that's confirmed with ultrasound as the best estimate of RA pressures. She has regular heart. There's a slight systolic murmur at the left sternal border. Her lung sounds are clear on the left side and nearly on the right side. Her abdomen is distended, but not extremely so. By contrast, her legs are very, very swollen, both of them, severe pitting edema. Slight asterixis.
Couldn't quite hear you, Zaven. How was the breath sounds on the right side?
Absent.
Okay.
Can you hear me now?
Yep.
So the breath sounds, yeah, were nearly absent, only at the very top, and then dull to percussion on that side with decreased fremitus.
Okay. So our exam does kind of help us start getting a little more specific with the differential diagnosis with both some abnormal pulmonary as well as potential cardiovascular findings in someone who has mild tachypnea and mild hypoxemia. I think the starting perhaps with the easiest piece to pick off is physical exam findings really consistent with a pleural effusion. As we mentioned before, patients with cirrhosis can get hepatic hydrothorax, accumulation of ascites that actually goes up because of the negative intrathoracic pressures into their chest. That is a big concern for her. But in the setting of a new pleural effusion, of course, we'll have to get diagnostics if that's indeed confirmed with our X-ray and ultrasound of the chest to verify exactly what that fluid is. But seems like there is something in our pleural space. Seems like it's really quite a lot of fluid and is an important driver for her dyspnea. But that's not the only thing that's abnormal here. We mentioned before, someone with cirrhosis, right? You guys have hopefully cared for patients with cirrhosis before. You know, usually their blood pressures are not super high. Hers is actually okay, but it's not typical to see, even in the state of total body volume overload, high intravascular filling pressures manifested in a high JV of 15. This is an important physical exam difference at baseline from someone, for example, with total body volume overload from decompensated heart failure versus total body volume overload from cirrhosis. So we really have to start pursuing why this patient has elevated filling pressures, because it's not well explained by the presence of the hepatic hydrothorax. We mentioned before the possibility of a cardiomyopathy, whether related to her cirrhosis, whether related to her prior history of alcohol use, or for other reasons. So I think elevated right-sided filling pressures because her left-sided filling pressures are high also is an important consideration. But with the presence of that murmur there, it was let me just see here, at the left sternal border, brings up the possibility of tricuspid pathology and what could be happening there. And then tracking even a bit closer into the lungs, the question is actually the period of significant filling pressure and high pressures from the pulmonary vasculature itself, as opposed to the left side of the heart. And the fourth complication, kind of pulmonary complication of cirrhosis that is now coming to me, is that you can get portal pulmonary hypertension, a form of hypertension, pulmonary hypertension and cirrhosis that can absolutely kind of lead to some tricuspid dysfunction if it's really severe, as well as elevated right-sided filling pressures on exam, which we are seeing. So I think besides the presence of the pleural effusion, we actually are worried about high pressures in the heart directly, which could translate to being a total cardiomyopathy versus problems with her pulmonary vasculature and right-sided heart dysfunction resulting therein. So I'm looking at the diagnostic work up in the chat. Totally agree. Got to get that X-ray, POCUS if we have it available, of the chest, and thoracentesis for what is likely a very, very large pleural effusion. And then Hans, I'm totally with you. We actually need an echocardiogram. Working up the pleural effusion alone is not going to resolve all of these abnormal physical exam findings. And I think very important to avoid premature closure on that being the main driver, given this great detailed physical exam that we have here that suggests there's another factor going on.
That was outstanding. I love that point by Hans that you emphasized, Steph. So I'll give you all of those results. So the X-ray does show a well-inflated and clear left lung, and then near complete opacification of the right hemithorax, just a little bit of air at the top, a little bit of lung, I mean. On bedside ultrasound, she has a massive and simple looking right pleural effusion, and actually very little to no ascites, just trace, like not enough to tap, but just a few drops around the bladder, a few drops around the liver. And then bedside echo, and then sort of a formal cardiac ultrasound to follow, both showed a very hyperdynamic LV, like with sort of the chamber almost completely obliterating with every contraction, The valves were normal. There was no tricuspid regurg. There was nothing stenotic. And then the right side looked okay. RV was not enlarged or pressurized appearing. And there was not enough tricuspid regurgitation to comment on pulmonary pressures. But the sort of with the presumption that they're probably not terribly elevated. And then assessment of kind of filling pressures based on the echo also kind of commented on a dilated IVC. So I guess that doesn't make too much progress. So let me also just give you the Pleural studies, or have everybody maybe think what Pleural studies would you want? In the meantime, I guess y'all can kind of type that into the chat or mention them. I can let me just give you the basic labs as well. Yeah. White count was 11. Hemoglobin was 9 or 10, something like that. Platelets 80. Chemistries, sodium 121. Potassium was 3.4. BUN creatinine was like 25 over 1.2. And then the total Billy was around 4, and INR around 1.6. Other LFTs sort of like as expected for cirrhosis. So yeah, so with that, next steps, next questions, go ahead. Hey, Steph, I can't hear you. I don't know if everyone else can, but.
Oops, sorry, I was talking with my mic muted. Was just seconding Eduardo's thoughts that we need the studies to actually look into the fluid, characterizing it as a transudate, which we expect it probably will be if this is hepatic hydrothorax versus an exudate. So we'll need both a serum as well as pleural LDH and total protein. And then I'll just mention that cirrhosis is one of the etiologies that someone can have chylothorax. Now, you can often make that diagnosis right away when you see the fluid coming out of the thoracentesis catheter, very milky, kind of milkshake-like look. So I don't think in most patients you have to preemptively necessarily think about that and check triglycerides, but cirrhosis is one of the categories that can actually cause that chylous accumulation of fluid. So it's not always simple transudative fluid when you have decompensated cirrhosis. So we'll get those going. One question I guess I have for the group is just now that we have the echo, kind of going back and explaining some of the physical exam findings, and Zaven, I'll be curious to hear what you guys found. It doesn't seem like there's a great explanation, at least on the echo, for her elevated filling pressures. No kind of major signs of an elevated pulmonary systolic pressure, tricuspid pathology, her hyperdynamic state. I also generally think of that as very nonspecific. If she's otherwise systemically unwell, she does have an anemia, although it's not profound. So I am not totally sure, looking retrospectively, how the non-pulmonary findings on our exam are well explained at this point. Did you guys have a good narrative for that at this time?
So I mean, I have my theory. It's not necessarily true, but I've actually generally found that the common kind of teaching that patients with cirrhosis have normal or low venous pressures, filling pressures, has not really held true in my experience. I think there are patients who at least don't seem to have cardiomyopathy, don't seem to have advanced CKD, don't seem to have portopulmonary hypertension. I think still can have elevated venous pressures, and that's also consistent with the physiology that I know of, which is that yes, there's vasodilation. But there's also renal vasoconstriction, sort of as part of the hemodynamic kind of vasoactive milieu of cirrhosis. So, so certainly in frank hepatorenal syndrome, but even before that, like the kidneys are not being perfused, and that's how you get edema, right? That's how you get retention of salt and water. And I think just like in heart failure, that's the same mechanism. The kidneys feel like they're not being perfused. There's neurohormonal stimulation, and they overshoot, over retain the salt and water. I think that can happen in cirrhosis. That's based on my experience. There's a couple of studies too that have actually done invasive hemodynamic assessment of venous pressures in patients with sort of cirrhosis and volume overload, and not necessarily with concurrent cardiomyopathy, that show that in a minority of patients. So that's my, and again, we looked for stuff and didn't find it. So that's my best understanding. You could say that's because of renal dysfunction, but yeah, all fluid retention is because of renal dysfunction, right? One way or another. The final common pathway is the kidneys not excreting what they should. But to me, the primary mover of that is the cirrhosis.
Yeah, interesting. So just that thought that intravascular overload isn't there, really not necessarily being physiologically driven.
Yeah, and that's not to say that we shouldn't always look for concurrent cardiac disease and pulmonary hypertension, et cetera. But yeah, I just have sort of an accumulating evidence that we often look and don't find. So
yeah, great. And just shout out Abby in the chat, just mentioning generally, right? Expanding beyond all of this being related to the cirrhosis, thinking about nutrition. And I think, worrying about thiamine deficiency, wet berry, really very valuable. I think based on her kind of nutritional history, if she really is at risk, that is an important consideration in a diagnosis we often make very, very late, worrying about specifically B1 deficiency. Only other comment I'll make, often people are pointing out that creatinine is, even though maybe normal by the computer, probably is not for this lady with a limited muscle mass. And so kind of adding this new problem of acute kidney injury to her list.
Very astute. So the Pleural studies, yeah. The protein and LDH were both very low, consistent with transudative effusion. The cell count was around 70 or 80, mostly lymphocytes. And the cytology and cultures were both negative for what they respectively look for. So I guess if y'all want to just sort of like commit to, I guess, the a diagnosis, if you want to name it, maybe we can spend a little time talking about management.
I'll let others chime in first. Any thoughts on likely work in diagnosis here? So question about potential infectious effusion. I think big concern, right? Initially having a very broad differential for the fluid, the transudative properties of the fluid, as well as the low cell count, reassuring, likely against that. And yeah, other thoughts about this being directly related to her decompensated cirrhosis. Yeah, I think hepatic hydrothorax probably fits best right now. I'll just comment that having the cell count as part of the initial workup, very important, not just to help with the diagnosis of what the fluid is, but to also rule out complications that can happen with pleural effusions in patients with cirrhosis when it's from hepatic hydrothorax. We know ascites in the abdomen can spontaneously get infected by translocation of gut bacteria. Well, that same thing can happen when the ascites is up in your chest. And so that cell count is very helpful to make sure that this likely hepatic thorax doesn't have spontaneous bacterial empyema, essentially the pleural effusion equivalent of SBP, which we certainly would have checked for in this lady if she had enough ascites. Zaven, we'll let you take it away with thoughts on the management.
Well, I want to know what the chat thinks. Let me challenge y'all to say how would you treat this patient? If you know, share. If you don't know, ask the questions that you'd like answered, and Steph and I can try to answer. Yes, that is correct, by the way. The diagnosis was hepatic hydrothorax. Robbie, while people are thinking about how to treat this person, did you disconnect and reconnect by chance? Yeah. Okay. So I
feel good that Robbie had the same question I did.
So okay, you're about to feel even better. Okay. So the first time that my experience that patients with cirrhosis can have elevated filling pressures without concurrent cardiomyopathy or pulmonary hypertension came when I shared a case on Human Diagnosis Project some years ago, and actually Guppreet reached out to me and said, "Hey, I'm really curious about how this patient had why this patient had elevated JVP." And that patient in question had she had like a JVP of 25, 30, like very, very high. She was younger, and also had a totally normal echo, included normal right-sided pressures. And Robbie, I was just saying that I think both, again, with my experience with these two patients, but many others, as well as pathophysiologically, I think when the kidneys are hypoperfused in a setting of cirrhosis, that is both inappropriate vasodilation and shunting of blood to the skin, to the gut, but it's also, there's thought to be a mechanism of intrarenal vasoconstriction, and that the salt and water retention that is driven by that renal hypoperfusion can overshoot euvolemia and cause both intra and extravascular fluid overload. That's my theory. It's somewhat supported by a couple of studies that I've found that did invasive hemodynamic measurements in patients with cirrhosis and without heart disease that did find elevated filling pressures in a minority of patients. So that's my best guess.
You just muted yourself, Zaven, but you've made your case.
Okay, so awesome. People want a therapeutic thoracentesis, not just the diagnostics. And indeed, this patient underwent several thoracentesis over the subsequent week and a half, each time relieving like almost 2 liters of fluid and feeling symptomatically better. But then unfortunately reaccumulating the effusion quite rapidly, because concurrently we were also administering loop diuretics at increasing doses and not having a ton of luck. In fact, with augmenting the urine output and helping her pee out some of the accumulated fluid that is both in her chest as well as everywhere. And her creatinine actually started to worsen, increase, and let me pause there and ask y'all to consider sort of this evolution of events, and also think about her kidney function, like I think somebody just did in the chat, as well as her serum sodium, and how those things interplay, and what other therapies or considerations we should have now.
Dale, I think your question, Dale's asking, Zaven, do you give albumin for large volume thoracenteses the way you do for large volume paracenteses? I'll be curious if there's more on this. My thought, Dale, would be, in theory, you would, if you took out more than 5 liters of pleural fluid at a time. That is the threshold at which the evidence favors volume expansion with albumin. If you do a paracentesis and you only take out a couple liters, you actually don't give albumin. I don't think anyone is frequently safely getting 5 liters out of their pleural cavity. And so I think for that reason, simply being the absolute volumes are not as high as we can get out of the peritoneal cavity, albumin isn't given. It's not that it wouldn't be in theory. Do you agree with that, Zaven?
Yeah, couldn't have said it better myself. Totally.
Yes, and Abby, great point, right? Higher volume pleural thoracenteses can have their own complications with the procedure, like re-expansion, discomfort, pulmonary edema. So great point. Yeah, my kind of worry, which seems consistent with what others are saying in the chat, we're getting in between a rock and a hard place of really having persistent volume overload, reaccumulation of this fluid in the chest, but running into a limitation with her worsening renal function of how much we can manage this with diuretics alone. So the question becomes, you know, what people know about next steps, kind of what do you do when it's sort of diuretic resistant or refractory based on inability to uptitrate further from renal or hemodynamic factors. What do we do for this lady? Because it keeps coming back, huh?
Yeah, and I think I'm seeing a lot of focus right in the kidneys in the chat relative to that question, and that is the key question. Like why aren't the diuretics working? Why aren't the kidneys responding? And the answer is that they're just that sodium avid, right? They are feeling hypoperfusion just that much, and the hepatorenal physiology that may have been in the background and sort of, again, is the pathophysiologic driving force of fluid retention and cirrhosis is now actually resulting in a drop in the GFR and diuretic resistance because of just very severe kind of revving up of the compensatory sort of salt retention mechanisms. We obviously we're consulting with our hepatologist and nephrologist and decided to kind of treat the patient presumptively with for hepatorenal syndrome. She was started on octreotide and midodrine. She did receive some albumin, although there was a little bit of concern that in a patient who is already volume expanded, that further elevating the venous pressures may not necessarily be beneficial. The combination of those therapies ended up augmenting the urine output and actually stabilizing the creatinine a little bit and stabilizing the overall kind of volume overloaded state of the patient. So in parallel, the patient was undergoing evaluation for a transplant because actually he may be a good candidate, and one of the reasons why TIPS is a good idea, Abhi, but was deferred is that in a pre-transplant kind of transplant candidate setting, it's not recommended because it can precipitate worsening encephalopathy. It can also precipitate worsening liver failure. For that reason, it was deferred because otherwise for a problem that is driven by portal hypertension, TIPS certainly could have led to some relief.
I hope for her sake his sake, they're headed towards transplant.
Yeah. Yes, indeed. I guess we've sort of had some good conversations and might be wrapping up, but let me ask one last sort of prompting question. What's up with the hyponatremia? Why, even though it's a pretty significant hyponatremia, none of us kind of focused on it, it seems. Nobody asked for workup that I noticed. And yeah, what do y'all make of the low serum sodium in this context?
That is actually, in retrospect, right? No one said anything, right? Or the 121, but we've had whole case discussions around that lab parameter as the chief concern. So yeah, thoughts coming in from the chat about kind of renin, angiotensin, aldo, ADH supreme activation, which is certainly present in this patient, perhaps being the main driver for ADH kind of appropriately being triggered based on the physiology that the kidneys were seeing.
Well said, Steph, and in the chat, yeah, right. So when you have hyponatremia and the patient is clearly, unequivocally hypervolemic with the known clinical context for that hypervolemia, it is just renin, angiotensin, aldosterone, and ADH, retaining water even out of proportion to how much salt is retained by the aldosterone. And I think the utility of sort of a lot of mental work or laboratory workup is marginal, and the treatment of choice is actually diuresis. But someone mentioned that diuretics can also cause hyponatremia, and that's absolutely correct. But different diuretics have different effects. So spironolactone can cause hyponatremia, but loop diuretics are often the answer to hypervolemic hyponatremia, as they lead to the excretion of water even more so than salt, and thus tend to correct the serum concentration of sodium rather than exacerbate it in most patients. So her sodium as well, when he started responding to diuretics, started to improve. Okay, that's all I have. I'm going to stop. We can end early if we want, or wrap up. So I'll turn it over to everybody else for reflection discussion.
Thanks, everyone. I think thinking through, starting very broad for this patient. And then honestly, as soon as we got a physical exam, really very tied into pleural pathologies and this question of primary cardiac also. I still don't, I think a lot of us would struggle how to manage her long-term. Anne-Marie made a point earlier on that keeping a drain in her chest, is very problematic for a lot of reasons. But clearly this lady is going to keep needing thoracenteses. I have a patient who's in this predicament on my service currently, who had a kind of unique approach. But I guess, Zaven, I'm just curious what discussions have happened around, hopefully resuming diuretics and keeping her at max doses as possible. But is she just going to get thoracenteses every week or a couple times per week until she gets a new liver? Or have alternatives kind of come up other than tips, which someone brought up, which was great?
So it's interesting. So what you say in terms of indwelling pleural catheters, generally that's still not sort of a common practice in hepatic hydrothorax. I learned when caring for this patient that liver transplant candidacy has to be first established based on sort of a good otherwise physiologic and organ function, right? Good social support, all that stuff. And then liver transplant allocation to those who are listed for liver transplant is based above all else on the MELD score, right? MELD sodium score, which predicts 3-month mortality and thus helps us to prioritize patients who are the sickest to get the first organs that become available. However, there are these things called MELD exemption points, which are elements outside of the MELD components, MELD as sodium components being bilirubin, creatinine, INR, and then sodium. And actually, refractory hepatic hydrothorax is one of them. And if you have had at least one weekly thoracentesis, if you have required at least one weekly thoracentesis for more than 4 instances, that actually, sort of gives you more priority for a liver transplant. And that is actually, it's almost like it's not the worst thing in some ways to require these thoracenteses. And in fact, if you were to put in a pleural catheter for whatever reason, then you would not be able to meet those exception points, even though you are actually just as sick, right? And that helped to prioritize this patient further actually on the transplant list.
Yeah, very, very interesting. Well, thank you, everyone. Really enjoyed getting your input, thinking through this case. Not, a common diagnosis. We treat a lot of patients with cirrhosis, but I think some really nice, both diagnostic as well as nice high-level kind of management reasoning when it comes to what do we do next and what the options are, what the limitations for the options. So thanks for bringing it forward, Zaven. Always fun to chat this way. Ibrahim, want to take it home with some teaching points?
I think it's Muhammad who's doing teaching points. So.
Oh, thank you. Mohammed, we'll turn it over to you.
All right, you could go, Ibrahim, if you want to. So we had a 50-year-old woman with alcohol-associated cirrhosis diagnosed 2 years ago, and who presented with dyspnea for 3 weeks, progressive in nature and at rest. She had orthopnea. Upon exam, she had absent breath sounds and right pleural effusion. She was diagnosed with hepatic hydrothorax. So we approached the case first with basically we tackled dyspnea as usual, is the general approach of dyspnea. And then in such a patient with cirrhosis, we focused on other etiologies, such as ascites, abdominal distension, hepatic hydrothorax, and hepatopulmonary syndrome, anemia in cirrhotic patients, and cirrhosis-related cardiomyopathy. And we also discussed that the diaphragm in those patients with massive ascites could be impaired. Its mobility could be impaired, leading to dyspnea. So we already entertained that thought. And the interesting finding in that patient is that she had a elevated JVD, but no other cardiac causes clearly explaining the elevated JVD, apart from just a tricuspid regurgitant murmur. And we also we spoke about basically different causes when we have elevated JVD in cirrhotic patients. We think of concurrent etiologies that could lead to elevated JVD or right-sided congestion, plus other causes such as portopulmonary hypertension. And in that case, it's very important to get a pleural fluid analysis, which we also said could be chylous and not always transitive. However, usually chylothoraces are usually exudative, but in cirrhotic patients, it could be transitive. Hepatic hydrothorax is usually on the right side, such as in our patient. It's because of the diaphragmatic defect and usually unilateral. And also with the pleural fluid analysis, very important to rule out infection. So always get pleural fluid cell count and the other indices to just differentiate and also rule out potential complications. And cirrhotic patients could have elevated JVD in the absence of cardiac causes. And potential explanation was the metabolic changes, such as the retention of sodium and water in such patients, leading to volume overload and lower limb edema, elevated JVD. The treatment of hepatic hydrothorax is the same as ascites treatment, and we also spoke about the albumin being important in such patients when the pleural fluid drain is more than 5 liters. And hyponatremia in cirrhosis, usually defined as less than 130, and in our patient, the patient had a sodium count of 121. So in the right clinical context, it's usually due to physiological response due to low effective arterial blood volume, and elevated RAS, and appropriately elevated ADH. Thank you so much, Dr. Zaven and Dr. Steph, such a great case, and thank you, everyone.
Thank you, Mohammed. Great to see you guys. Looking forward to next time. Take care.